screen from MIER and Dr. Sanjeev Singh, the director at the Amrita Institute of Medical Sciences. We welcome all the participants from Nepal, Bangladesh, Philippines, Singapore, and India to this 5-day bonanza of interactive learning on the implementation of antibiotic stewardship in a resource-limited setting. The workshop that we've structured for you is hopefully to cause minimal disturbance in your daily life, yet give you a small dose of daily food for thought. The sessions are structured into 2.5 hours a day from 4 p.m. to 6:30 p.m. IST with a very highly knowledgeable and expert international faculty speaking for 2 hours. So there are sections, there will be 4 speakers to 6 speakers a day. And these hours are followed by half an hour of interaction time with the Any participants who have queries are requested to put their queries in the comments or discussion box and with your name on it. And if you have directed it to a particular speaker, please put the name of the speaker as well. Request all participants to keep themselves muted during this time. And in case you are in a personal setting, request you to also keep the videos off. All participants are also requested to fill the pre-workshop questionnaire. This questionnaire has been shared with you on your email that you have registered with us. This email you would have received from a mail called the research@medanta.org. So this is the group that would have emailed you. So please use this email to respond to this questionnaire. This questionnaire is very important because this is what the pre-questionnaire, if you fill today, and the post-questionnaire when you fill later, is the one that will actually help generate your certificates of participation in this conference. We will also be sharing a daily feedback session form for each session. So today's session, once it completes, we will send you out a feedback form link. Request you to take 2 minutes so to help us prepare for the session tomorrow and the following days. I would also like to take a minute to thank Pfizer for supporting this workshop with an educational grant, enabling us to actually expand to various borders. So the welcome address for today's session is from Dr. Nirmal Ganguly. Dr. Ganguly is a trained microbiologist and has led the Indian Council of Medical Research for 2 terms as the Director General. He was formerly the president of Jawaharlal Institute of Postgraduate Medical Education and Research, that's JIPMER, Pondicherry, as well as the ancient Asian Institute of Public Health, Bhubaneswar, Orissa, and the former director of PGI-MER, Chandigarh. Sir has received one of the highest civilian honors that India gives, which is the Padma Bhushan, for his work in medicine. I will request Nikita to please continue with Dr. Ganguly's address.
That Medanta is taking up a particular enterprise in creating antimicrobial stewardship in resource-limited settings. Normally, antimicrobial stewardship has prospered into hospitals which are very nicely entrenched and have strong infrastructure, and antimicrobial stewardship has helped them in attaining the goals of treating the patients rationally, creating appropriate auditing of the pharmacy as well as the prescriptions which are done, and creating data sets which provides that whether the antimicrobial stewardship is working or not. It also provides very strong surveillance data from which you could really see that whether the hospital is improving in its functionality. And this particular part is done at every aspect of the hospital functioning. So the one which has been funded by ICMR, the network has already been established and very valuable data and the training programs has been undertaken. However, in the hospitals in resource limited settings, this is not in place. And we need to create a matrix of the minimum requirement and standard setting for those purposes. It is a costly endeavor. And to really attain this, they will need not only training, as well as they will need some monetary help to put the systems in place. And I'm happy that Pfizer is funding this enterprise at this moment to create a positive thinking about these. We are having a discussion in the Niti Aayog on 15th that how the antimicrobial resistance could be enhanced. And the NABH also in its brainstorming session has tried to put antimicrobial resistance as the hospital standardization and the quality functioning of the hospitals. So it will be very interesting to know that if a matrix and funding source could be found and a network could be created of the hospitals which are in the B or C class cities or the district hospitals and even the government hospitals which are working on limited budgets. This will go a long way in really looking at the whole picture and putting the standards in places in entire country setting, which will have a huge impact on the use of the antimicrobials as well as in the surveillance and the training programs and overall functionings of the hospital. And it will also help in their accreditation. So this particular discussion will be of a great interest and will be useful for everyone who has an interest in this particular area. I will be very happy that if with this particular conference, we could really cover at least one state in which Medanta is situated, that is the Haryana state. If we could cover the Haryana state itself, the model will be very, very useful, and we could then look and implement it at other states. So I'm looking forward to the deliberations as well as the matrix which is created, and we'll also be looking very closely at that how the funding could be affected without having any conflict of interest. Thank you very much for inviting me.
Thank you so much, everyone, for bearing with us with all those glitches. I'm hoping that the next one will have no glitches anymore. So the next speaker is Dr. Naresh Trehan. Dr. Trehan is a cardiac surgeon as well as the chairman and managing director of the Medanta hospitals. He has received the Padma Bhushan and the Padma Shri presented by the government of India for his work in healthcare. He is a visionary leader and it's a pleasure to hear him speak. So Nikita, can we go ahead with Sir's address, please?
I'm Dr. Naresh, and I have the pleasure of being with you people discussing the all-important subject, implementing antimicrobial stewardship program in LMIC regions. The basic importance of antimicrobial stewardship is to monitor how bacteria are getting resistant to the existing armamentarium of antibiotics. So, overall, for the health of any institution and its ability to give the best of healthcare to their patients, it's important that a good mapping is done of how the bacteria in a given environment are developing, how sensitive they are to our current regime, and what is the trend when are they getting resistant to the current availability, or are you requiring higher and higher level of antibiotics? Of course, it adds to the expense also, but it also, if you get resistant to that, then that's the last mile. So that's why I think it's a very all-important subject to be addressed. And I'm glad you are doing this whole program over from 13th to the 17th. Now, today, of course, the challenge is because of pandemic that they have to be done mostly on virtual platform, but also there is beginning of some physical attendance too. So I think that if we go down the list of our speakers and the galaxy of speakers from around the world. So that's the important part of it, is that there is sharing going on between the mapping for antimicrobial stewardship programs from outside to countries like India, to countries like in South Asia and extended East Asia. So there is a huge amount of benefit that can be derived from the fact that we already have the intelligence system in place, so that if we see that antibiotics are not being used judiciously, or in given pockets that there are resistant bacteria developing, we can immediately take remedial action. And I think that is all important, because the world is running out of antibiotics. The bacteria are very hardcore, you can say, that they keep getting resistant to newer and newer antibiotics. And there aren't that many antibiotics coming down the pike right now. So the world is worried. We are all worried. And I think your contribution to knowledge, the way you people will also, the attendees will learn from the experts, will go a long way in preventing bacterial resistance, or at least stopping it from evolving so fast. So good luck for the conference, and anything we can do from Medanta education and research to help the attendees or the trainees, will be very happy to do so. Thank you very much. Have a good meeting and an enjoyable time. Bye.
So thank you to Dr. Trehan. The next speaker for today is Dr. Girdhar Gyani. Dr. Gyani is a healthcare administrator par excellence. He is the Director General of the Association of Healthcare Providers in India. And it's very important, as we will go through the next few days, realizing that how important a role the healthcare administrators will play in antibiotic stewardship. So Dr. Gyani it is.
Let me introduce myself. My name is Dr. Girdhar Gyani. I am currently the Director General of Association of Healthcare Providers India, which represents vast majority of private hospitals in our country. At the outset, let me convey my heartiest greetings and thanks to Medanta Institute of Education and Research, which in support from Amrita Hospitals is organizing this particular program on antimicrobial stewardship. The antimicrobial stewardship, as we understand, is the systematic approach in improving antimicrobial use with a view to improve clinical outcomes and minimizing the adverse events, including development of antimicrobial resistance. In hospitals, the resistance to antibiotics and antifungal poses the greatest concern. I was going through a report by which says that more than half of antibiotic prescribing for selected events in hospitals was not consistent with the recommended practices. To cite a few examples, in 79% of patients with community-acquired pneumonia and 77% of patients with urinary tract infection, these practices were not found to be followed. Hospitals prescribe and pharmacists, let us include, need to improve the antibiotic prescribing by optimizing selection, reassessing antibiotic treatment, and possibly using the shortest possible duration of therapy. In this case, I would like to say that hospital leadership, especially the chief clinical director, chief nursing officer, and director of pharmacy need to play key role. Organizing regular review meetings by each specialty head along with the fellow clinicians, nursing staffs attached to that particular specialty, administrative staff, diagnosis staff, if they can hold this regular meeting for reviewing the cases, it can really bring the big change in improving the antibiotic stewardship program. Importance of antimicrobial stewardship program can be gauged by the simple fact that thousands of mortalities are attributed to the antimicrobial resistance. And as per one report, trillions of dollars are expected to be spent on it by 2030. It is therefore important that antimicrobial stewardship is given the urgent attention. We need to adopt systematic approach to implement and institutionalize such key program. For example, this subject must be introduced in the curriculum for UG, PG programs, nursing programs, pharmacist program, and even in the curriculum of the allied healthcare, who constitute around 60% of the hospital staff. Emphasis is to be needed by accrediting and certifying agencies. As we understand, most of the hospitals these days are accredited, and if the accrediting agency at the time of assessment and auditing, if they put a specific emphasis on assessing the practices for the antimicrobial prescription, it can go a long way. Another important attention is to be given by the regulating agency if they can also include this aspect in the regulation. The paying agency, that is insurance companies, equally can play a good role, and they can introduce this as one of the incentives. And I will also suggest that government and the private agency can lay the specific emphasis on carrying out the research activities, as we understand that new antibiotics are hard to come, and this research can also assess the trend from the past practices. We also can consider relicensing of the doctor and nurses, whether they are well versed with the current practices of prescribing. Association of healthcare providers is keen to play a key role. In fact, we are already working on this subject. There are 3,000 hospitals in our country with a bed size of 100 and above. These can become the resource center in spreading the awareness on the subject. Particularly, as we understand, there are more than 40,000 hospitals with a smaller nursing home. They need to be made aware about these practices. And finally, I will once again convey the commitment of Association of Healthcare Providers to work wholeheartedly with the institutions such as Medanta Institute and the Amrita Institute to carry forward this program across the country. Thank you very much.
Thanks to Dr. Gyani for a wonderful, actually he summarized what is really needed of this workshop. So thanks to him. In the first session today, the last speaker is Dr. Yatin Mehta. Dr. Yatin Mehta is the chairman of the Medanta Institute of Critical Care and Anesthesiology. He is additionally he's a recognized leader in the area of antibiotic stewardship and chairs our antibiotic stewardship committee at Medanta. He's actually helped run a protocol modifying the Hopkins CUSP protocol for antibiotic stewardship and rolled it out at Medanta. We will be sharing this experience with you on probably day 3 or day 4. Request Nikita to play words.
I would like to welcome you all for this course on implementing antimicrobial stewardship program in low and middle income country regions. It's a very innovative program and it's a good beginning for this very serious issue which we all have in the developing countries. I thank Medanta Institute of Education and Research and Amrita Hospitals for facilitating this, and particularly Dr. Pooja Sharma, who has worked pretty hard to put it all together. So, I think in the issues which we face in the Southeast Asian and Central Asian countries are quite different. The magnitude is humongous. Hospital-acquired infections are 5 to 10 times more than those in the developed countries, which we have done it in INIC publications, we have shown it many, many times. And besides that, because of that, probably, the antimicrobial resistance is increasing every year. So we see a tremendous change in the last 10 years. So on one hand, you are resource limited. On the other hand, you have a high incidence. And thirdly, you have very high antimicrobial resistance. So all these three things put together leads to substantial increase in morbidity and mortality and cost in all these countries. So a lot of thought process has gone into putting this all together. We have speakers from different parts of the world, from US, from UK, from Belgium, from Asian countries, India, Bangladesh, Philippines, Hong Kong, Singapore. I think it will be a very good program for everybody who deals with patient care and antimicrobial stewardship. Next 5 days. And it's structured in such a manner that it is in the evening, so by and large you have finished your clinical work, so everybody can attend. Otherwise, full 2-3 days is very difficult for people to give it to. It starts with what is the required need for this, what is the incidence of hospital-acquired infections and antimicrobial resistance, and then there are talks from different parts of the world that what are the specific issues in their own countries. Also, how to put it all together, how to structure this program in your own institution, and who are the people. All the stakeholders are giving presenting modules, starting with obviously the clinicians, the microbiologists, the pharmacy people, the nurses, the most important, and the IT. So these are the different parts which all should fit together to be able to run an effective antimicrobial stewardship program. And also there are cultural issues in the developing countries, which I must point out too, that some of these societies and the way we have grown or not grown, I would say, it's a little feudal mentality some of the clinicians have, that I have been doing it for so many years, this is my patient, what I have said is gospel truth, and evidence-based medicine becomes experience-based medicine. So that's the reason we need to have a futuristic vision, and we need to be amenable to changes. And maybe some of these modules at the end of this course, some of us will be converted by the time we go home. So I think let us all put our heads together and we may be able to develop some sort of antimicrobial stewardship program in your own organization and own institution. And I wish you all a very productive next 5 days. Thank you very much.
So thank you for that. I see a lot of people are asking for the link, and the link seems not to be opening for the pre-test. We will be sending out the link from the IT host in a minute. Please give us that time. So in the next, please enjoy the session being coordinated by Dr. Sanjeev Singh. I will hand over the podium to him. He is the director of Amrita Institute of Medical Sciences. May I request Dr. Sanjeev to please take over. IT will have to allow Dr. Sanjeev to unmute himself.
Fantastic. I think IT worked on me first, and that's good to know. Thank you, Dr. Pooja, and I would like to congratulate you for organizing, putting all the hard work in organizing this 5-day conference. I think it is so very, very important, and you and your team have been excellent. So you have done the hardest of the work, and I appreciate all the efforts which you have put in. And Dr. Sharmila, she has been the spine and the guidance factor for all of us, and she got the conceptualized, she got the team together, and she got all the fundamentals to organize the workshop together. So thank you, Dr. Sharmila, for all the help and support. So what the whole workshop, it has been planned. Today is the day 1 where we would have the leaders who have done huge work across the globe on antimicrobial stewardship. They're going to speak, they're going to share their experience. Day 2, we are going to have some of the strategies to implement. As Dr. Yatin just said, that there need to be a take-home of the workshop which we are conducting, and take-home would be those strategies of implementation, more so in an LMIC because the settings would be different. In day 3, we are looking at conceptualizing, operationalizing, monitoring, evaluation, and feedback. And it was also brought in very well by Dr. Girdhar Gyani and Dr. Naresh Trehan, that one, you need to put a good structure and process in place, but it is important that it is monitored, and we will see the surveillance structure as well as the IT guidance towards that. Day 4, we look at challenges. It's not very easy to go ahead and implement antimicrobial stewardship, though we agree that there are a lot of institutions who have done fantastic work. But those are still islands of excellence, and they are in silos. We need to have a very coordinated approach between good tertiary care hospitals and secondary and primary care. So we look at those challenges, but it also imposes huge opportunity for all of us. And day 5, we will be looking at some of the case studies and see how we could create a difference in LMIC. So let us get started. And our first speaker is a very good friend of mine, Dr. Sumanth, who have been working so very hard when he was in India and now when he is in US. He did his master's in public health from East Kentucky. He did his MD in infectious diseases from Massachusetts Institute. He has also done his medical microbiology from University of Chicago. And right now he is at Washington University Barnes-Jewish Hospital as an associate hospital epidemiologist, and is also member of WHO expert committee on essential medicine. And Dr. Sumanth would be speaking on global impact of antimicrobial resistance, the silent pandemic. So over to you, Dr. Sumanth. And thank you very much for accepting and joining us live. I know it's going to be very, very early for you, but we really appreciate that.
Can you hear me now? Okay, good. All right. So, all right, I'm going to share my slides. Okay. All right. Good afternoon and good evening, everybody. And thank you, Dr. Singh and Dr. Sharmila for giving me opportunity to present at this workshop. And so I'm going to speak about the global impact of antimicrobial resistance, the silent pandemic. And I'll start to say that I don't have any conflicts to declare. All right, so I'm going to start with this basic slide, considering the audience that we have. Basically, you know, what are antimicrobials, and it includes antibiotics, antiviral, antifungal, and antiparasitic agents, you know, which are used to treat and prevent infections in humans, animals, and plants. And antimicrobial resistance, you know, refers to basically the, you know, when the bacteria or fungi or parasites change over time and no longer work, you know, work against the medicines, no longer respond to the medicines, which make the infections harder to treat, leading to severe illness or death. And again, I think most of the slides that I present is all about antibacterial resistance or antibiotic resistance. So I think that is the general impression when we talk about antimicrobial resistance, but not saying that, you know, there is resistance in fungi as well. But most of my talk is geared towards the antibiotic resistance. So probably many of you know that, you know, bacteria are older than all humans, and they evolved over billions of years. And most of the antibiotics that we have today are basically natural products, and to which the bacteria has been exposed over and over. So this slide basically shows that, you know, antibiotic resistance is inevitable. You know, there's nothing that you can avoid happening. It's only how best you can manage. So this one shows basically, you know, when the antibiotic was introduced and then when the resistance was detected in bacteria. And as you can see, some antibiotics, the resistance occurred within the same year, but for some antibiotics, it took a couple of years to develop. But essentially, what this means is, you know, antibiotic resistance is inevitable. For any antibiotic we introduce, you will expect to have resistance develop. And this slide is showing the prevalence of ceftriaxone-resistant E. coli, which is, you know, one of the common pathogen leading infections in the community as well as hospital. And in this slide, you know, there are two things. One is the prevalence is higher in low-income countries, and if you see Western Europe or North America or Australia, the prevalence is much lower compared to countries like India. And this is, we're talking about resistance in bloodstream infections from which E. coli is isolated. On the right side of the slide, you can see that the antibiotic resistance is increasing. The prevalence of E. coli, ceftriaxone-resistant E. coli is increasing over time. And as you can see, it's increasing across the board, not only in high-income countries, but also in low-income countries. But why are we talking about antibiotic resistance at this juncture now? So the reason is, as somebody already alluded to, that there is a discovery void. You know, the golden era of antibiotics was between 1950 to 1980 when so many antibiotics were discovered. But suddenly after 1980s, and we don't have any new antibiotics. And so, you know, we are in a situation where the resistance bacteria are increasing, but we don't have new antibiotics to, you know, treat those infections. And one of the major reasons why we have this discovery void is basically, you know, economics. And you know, antibiotics aren't profitable to any pharmaceutical companies. And this is mainly attributed to how antibiotics are given. So, you know, if you're taking a medicine for high blood pressure or cholesterol or any of the chronic degenerative diseases now, you have medicines that you can, once you start, you can take for the rest of your life. But for antibiotics, that's not the case. You either give for 1 week or 2 weeks, sometimes 6 weeks maximum, and there's not much incentive for the pharmaceutical companies to develop. So that's why they stopped investing into antibiotics in 1990, 1980. So that's why we don't see new antibiotics in the market right now. And there have been a lot of efforts to bring big pharma back into the discovery of antibiotics, but just want to allude to the point that the reason why we have this discovery void. So coming to the point about the burden, so we have as of now, this is the report commissioned by the UK government, and they came up with the estimates of antimicrobial resistance deaths. What's happening in the year 2016 and versus what's going to happen in 2050. So it's estimated that the deaths will be about 10 million in 2050, and again, assuming that there are no new antibiotics discovered and the resistance continues to go up, without any change. But we also need to include that these estimates also include not just bacterial infections, but also includes TB and also HIV. So it's not just pure, but you need to be aware that these numbers are not just reflecting bacterial infections. But the most important thing is that the 90% of these 10 billion infections that happen, or deaths that will happen in low-income countries, mainly Africa and Asia. I think that's the biggest problem, why we need to really invest now to, prevent these episodes in low-income countries, because it's estimated that because of the high prevalence of infections in low-income countries, we are expected to see high number of deaths going forward. And not only that, antibiotic resistance it plays a key role in terms of how modern medicine works. You need to have effective antibiotics to perform routine surgeries. You give prophylaxis for surgery so that we want to prevent infections, and cancer chemotherapy. To sustain chemotherapy, and we need effective antibiotics so that you can recover. If there is any infection from chemotherapy or also organ transplantation. So this is just a study, showing that if there is a reduction, this is a modeling study, and it's restricted to United States. When there is a 30% reduction in the efficacy of antibiotic prophylaxis, we would have these many additional infections and additional deaths per year. So all, this paper is trying to say is that the modern medicine really depends on having effective antibiotics. So why are the bacteria getting resistant to antibiotics? And I think one of the main and primary reason is overuse and misuse of antibiotics. There are several other reasons, why this is happening, but the primary reason would be, we tend to overuse antibiotics, and also there's a lot of misuse of antibiotics. And if you look at the low and middle income countries, we did a review about, how often antibiotics are prescribed in a primary care setting. And so the systematic review included about 27 countries, studies from 27 countries. And what we reported was basically every other patient presenting to primary care basically gets an antibiotic. And if you look at that, and how many of these probably would be an inappropriate or unnecessary, is going to be another 30 to 50%. So basically, you're giving antibiotic for every other person, but among those, one is probably unnecessary. So there is a huge amount of overuse of antibiotics in low and income countries. And this slide is showing basically the trends of antibiotic use globally, and from 2000 to 2014, and you divide it by high income countries, low income countries, and upper middle income, low income countries, and you can see that the antibiotic use in the high-income countries kind of, is flat, or I would say, going down. But what you really see is increasing antibiotic use in low-income countries, and that's a good sign that it's we are increasing access to antibiotics. But as I mentioned, that there is probably a significant amount of misuse or overuse of antibiotics. And this is an example of how misuse can happen in low-income countries, as an example for COVID. And when COVID initially the pandemic started, the countries reported how antibiotics are used when COVID pandemic started. And on the left, you can see what happened in the United States, and then on the right, you can see what happened in London. And probably Dr. Holmes is here, so maybe she can shed light. But what this shows is that the antibiotic use actually went down when the peak of COVID epidemic or pandemic in US as well as in London in this particular case. Although there was a slight increase in the initial phase, but they quickly determined that antibiotics play no role in COVID. And then you can see in London, at least the second wave, there is no increase in antibiotic use. But what happened in India is totally different. This is a slide showing the antibiotic consumption during the peak first wave for COVID in India. And as you can see, the pink bars are the COVID cases, and the green line is total antibiotics, blue line is adult formulations, and then the red line is the pediatric formulation. So, and there was a clear correlation with the number of cases of COVID and the antibiotic consumption, especially azithromycin use was correlated very well with the COVID cases. And when you look at over time, and what you see is basically we estimated that at least from June to September 2020, the peak time of COVID, there were 216 million doses of all excess antibiotics used, which we attribute that to COVID, and of which 38 million doses were for azithromycin alone, and that corresponds to like 6.2 million azithromycin treatment courses. And funny is that if you look at this time period, that's the amount of cases that you had. The COVID cases were about 6 million cases during that 4-month period. So it seems like everybody got an antibiotic. And this was the time period when most of the febrile infections that typically happen during the October season, or September, October, were the incidence was really half of what we expected from last year. But still, the antibiotic use continued despite that the febrile cases went down, and that was mainly attributed to COVID use. So in terms of the World Health Organization work on what is happening in terms of stewardship activities at the WHO, where I've been involved with the antibiotic committee, and we've been working since 2017 on improving stewardship activities, especially focused on low and middle income countries. So in 2017, the group came up with what we call a WARE classification of antibiotics, and which includes access group, watch, and reserve. And the goal is to basically indicate that access means that these are what we call narrow spectrum antibiotics, and these should be widely available and should be probably used in most situations and compared to the rest of the other groups. The watch group is basically, these are antibiotics like third generation cephalosporins and carbapenems, fluoroquinolones, which we want to restrict as much as possible, because these are broad spectrum agents, and the resistance could lead to lack of choice for treating these infections. When we developed this in 2017, this was basically an expert based classification of the antibiotics. And so we wanted to make sure that this is really true. And what we've done, and this is pending work that we have done, looked at, is there evidence to support this classification? And this is a huge systematic review and meta-analysis we did. And this is not published yet, but you can see that what we try to see is, how does antibiotics, various groups of antibiotics select for all these most important multi-drug resistant organisms. And what you can see is we reviewed about 180,000 studies, and ultimately we took data from 348 studies. And what this slide shows, basically, every antibiotic is associated with selection for resistant organism. But there is some sort of ranking, when you take these antibiotics. So what you see is basically, if you see the first drug is the first generation cephalosporin, the risk for selecting for any multi-drug resistant organism was the lowest with first generation cephalosporin. And as you can see, various classes of antibiotics, how the resistance selection is. So in short, the aware classification is appropriate, and it's appropriately ranks these antibiotics. And we should basically follow the aware categorization of antibiotics. Now, so what is happening in low-income countries is basically the trends of watch group antibiotics is increasing rapidly in low-income countries. And at least the study showed that 160% increase in consumption of watch group antibiotics happened in low-income countries. And what I highlight in the circles is basically, the difference. You can see what it was in 2000 versus what it is in 2015. So there is an increase in high-income countries, but that's about 28%. But a rapid increase is happening in low and middle-income countries. So what we're seeing is we are increasing the use of antibiotics in general in low-income countries, but also we are using more broad-spectrum antibiotics. So to help countries and health in low-income, to mainly low-income countries and healthcare systems to implement responsible antibiotics in the WHO, again as a group, we came up with the essential Medicineless antibiotic book. So this includes antibiotic recommendations for all common infections that you encounter in the community and in the hospital, and based upon the aware classification. So the expectation is that this should be to provide guidance for many low and middle income countries for antibiotic prescribing. And but of course, it doesn't supersede the national guidelines, but certainly augment, supplement in case if there are any discrepancies there. And this is currently in a public consultation phase, and we request everybody to review this and give comments as well. So, in conclusion, antimicrobial resistance is a major global public health threat, and again, I'm mainly referring to antibiotic resistance. And what we see is that it disproportionately impacts low and income countries, and especially in terms of the resistance, as well as the increased use, especially the broad spectrum use. So we really need urgent measures to curb the use of misuse of antibiotics, and obviously the stewardship program is the key in helping that process. All right, that's all I have.
Yeah, perfect. So thank you, Dr. Sumanth, for taking us through those very, very important steps and highlighting that it is becoming grave, it is becoming deadly, at least in LMIC. It's there throughout the world, but at least in LMIC, and we really need to have appropriate strategies and pull up our socks and work towards a better stewardship program across. And you had shown that in primary setup. You have shown that in the secondary and tertiary setup. So please stay with us. I know it's going to be slightly tough for you, but please stay with us. We'll have the question answer sessions. So I will now go ahead and introduce one of my mentors, Dr. Alison Holmes, and she does global work and global incredible work. She's a professor of infectious diseases and both at NIHR unit and healthcare associated infections and AMR, looking also at the Center for Antimicrobial Optimization at Imperial College. And what she does is something amazing. She brings in people, she gets all the group of people across the world together. She writes fantastic proposals, she does superb work. And it is amazing to see that she has done work in artificial intelligence, she has done work in technology, she's done superb work in social sciences, she's doing work in AMR, she's doing work in HAI. So she's almost there at every place wherever HAI and AMR is, including epidemiology and public health. And it's such a pleasure, Alison, to work with you and to keep learning with you. So Alison, Professor of Faculty of Medicine, she's going to speak on leadership and who could deliver it best other than Alison, key to antimicrobial stewardship. So over to you, Alison.
Thank you so much, Sanjeev. Can I just check that you can see my screen?
Yeah, we can. We can hear you.
Good. And can I just check that it is in the appropriate mode? Can you see that, Sanjeev? Is that okay?
Yeah, it is. Oh. But we are able to also see your second slide. So.
Ooh, okay, let me sort that out. Like that.
Yeah, perfect.
Excellent. Thank you so much. Well, what a pleasure to be here. Thank you, Sharmila, and thank you, Sanjeev. And I've been asked to talk about leadership, but I just want to highlight how extraordinarily lucky I am that I actually work with such amazing leaders and collaborate with such amazing leaders. So I am going to talk about some aspects of leadership, and I'm certainly no expert, but I've got some experience. And I just wanted to also consider and reflect about how much has changed, and those extraordinary introductory remarks have actually shown how much things have changed regarding antimicrobial stewardship and indeed in terms of leadership and commitment. So I thought those remarks were quite extraordinary. So I'm going to frame my talk on leadership around kind of what I think are some really important perspectives on antimicrobial stewardship. And those are 4 organizational and systems level perspectives, quality improvement and implementation, behavioral and social sciences, and finally research. And the reason I'm framing them like that are those are kind of 4 aspects that I continually am dealing with, and that this kind of nebulous concept of leadership permeates through them all. So I'm going to frame my short talk on those 4 aspects. So just to start with, something about leadership. You know, everybody has to read all sorts of leadership books. Many people are much more into this type of stuff. There's huge amounts of written about it, and I know very little. So I talked to a very good friend of mine who was a medic, who then went into organizational and leadership advice, told me to read this book, Max Landsberg, Tools of Leadership. I wish I'd read it a long time ago when it was a bit more useful. And there's some really interesting key points that are pretty universal, which are we're all obliged to lead something at some time. So whoever you are, wherever you are, you're going to have to lead something at some time, no matter whether you want to or not. But to be effective in a leadership role, you need these 3 things: vision, inspiration, and momentum. So those three important things. And I would add to it about how important it is to understand management. And many of us who have been in clinical roles and so much on the front line, you actually cannot understand management because you become such a kind of technical expert, or you know, you're just so stuck in your clinical role, you do not have time to understand management and organizational structures. And also in terms of leadership, there's something really critical about stepping back from it and create other leaders to do all that work for you, or with you, rather. So I want to spend just a moment on what happened in the UK, and happened to me. It now seems so long ago, but they introduced this concept of having a director for infection prevention and control within all hospitals or all NHS trusts. And this was to address not just infection prevention and control, but also antimicrobial stewardship. And this was because of the terrible problems with MRSA and then C. diff in the UK. So they created these leadership roles, and then they brought in the legislation to support these leadership roles. So this clinical leader had to report directly to the CEO and the board of the hospitals about what they were doing in terms of stewardship and IPC. And that really made you think about, oh my goodness, how can you run this across several hospitals and embed it in the organization? So in going along with an organizational perspective, I think AMS, we need to think about how we optimize individual patient care, but also deliver the public health agenda within acute health care. It's not enough to deal with individual care. You have to take care of all the patients around you and the future of your patients as well. And the issue around achieving safety and achieving good AMS requires more than individual carefulness. It absolutely has to be supported by the organization, and it needs to be a corporate responsibility, not just an individual one. And I think we heard a bit about that in the introductory remarks. And it just cannot be through an individual team or an individual person, no matter how super heroic they are and no matter how committed they are. It has to have an organizational approach. So we were very interested in this, and I was very lucky to have a couple of PhDs who came from the kind of management and organizational psychology realms of research who were looking into this. And I think there's some really, really fundamental things that need to be learned, which actually the influence across the organization may be extremely limited by the pathetic lack of strategic input of some of our keenest clinicians and ourselves, without making sure that we integrate it into governance structures and how we actually run our health systems and hospitals. So I really like this article by Sanjay Saint, who's marvelous. Now, he was writing this from an infection prevention perspective, and the leadership represented by infection prevention leads, particularly, of course, this was looking at the US, but highlighting how good these leaders already were in terms of delivering on patient safety and the patient safety agenda within hospitals. And what made them very effective leaders were having a clear vision, very good at conveying messages, and going back to that motivating and inspiring and having momentum, and focusing not on the barriers themselves, but how can you overcome them, and thinking strategically whilst acting locally, and never go to a committee meeting unless you actually know what you want to happen and you've already talked about it beforehand. And also, the aim should not be too abstract. It should all be about what we care most about, which is improving the health of our individual patients and the health of our population, and sticking to that. So this type of approach addresses this issue of much expertise, but it's not effective in changing practice and in changing things more strategically. Small teams and huge organizations going around firefighting, but not actually having major strategic input. And having expertise that's not closely linked to a management framework or embedded in systems to keep it sustaining through challenges, and embedding antimicrobial stewardship as a core part of how we deliver good care, a core part of clinical excellence. And we need to change culture and behavior and create an organization that's learning and ensure organizational leadership. And as I said before, it was really fantastic to hear those introductory remarks, which already demonstrate this is really progressing massively and is already occurring. So this was something that our chief medical officer at that time, Sally Davies, who's a major global leader in terms of antimicrobial stewardship, highlighted the importance of our hospital organizations in the NHS. It's our acute trust. Absolutely need to talk about organizational and behavioral change to reinforce policy implementation. And this was around antimicrobial stewardship and infection prevention and control. So if we're really wanting to change your organizations, we have to make sure we all believe in the same thing. We need to reinforce this belief, and we need to provide the skills to deliver what we want, and we need to have role models across the whole organization. So this is not all complete nonsense. A lot has been written about this. And this needs to be a shared vision, and everybody needs to understand their role in this. And very importantly, it needs chief executive complete and utter backing, providing that organizational positive reinforcement. And we need to make sure we use appropriate language. And as I said, patient care is central to that. Address local issues. You know, what are your patient populations? What are the problems in your institute? Deal with those before the more general ones, and make sure you have good data to look at how you're progressing and delivering on this, and use whatever is already existing in your organization to help you in this endeavor. When I talk about reinforcement systems, this is everything within the organization, how we report things to individuals, quality reports externally. Those all must include something about AMS if you're wanting to make it important. Also setting targets, measuring performance, granting rewards, whether it's to teams, units, whatever, all must be consistent with the behavior to be embraced. And for our purposes here and for this workshop, it's antimicrobial stewardship. So internal reinforcement, there needs to be leaders that are responsible for this. We also need to think about, do we need separate teams, or does that undermine rather than reinforce this? Are there existing teams or committees or groups that can deliver on this rather than creating something different? What can we use that's existing? And also, really importantly, what are the lines of accountability? And we've got to make sure that there are strong, clear lines of accountability with clinical leadership all the way along, to make sure that we understand where decision-making is, and of course, where resources can be found. And this is work from my wonderful colleague, Rahila Ahmad, who's written about this, and the importance of antimicrobial stewardship programs being completely transparent, because if they're invisible within the organization, you don't know where the resources are coming from, and then who is accountable for the delivery of this. So actually the programs need to be clear and have a structure within the organization with accountability. And if you want to integrate it with the wider quality improvement agenda, or have it dedicated to antimicrobial stewardship, integrated with IPC, doesn't matter, as long as they are identifiable. So in terms of external reinforcement, this can be professional status, peer recognition, reward, promotions, incentives, targets. Externally also statutory monitoring, data in the public domain, public awareness, and what our patient population and civil society want to see. And also importantly, something we don't discuss too much, but I'll pick it up at the end, which is the research agenda. And I just want to say, in the UK, I tell you what's a really strong external reinforcement is the media interest. And that really does put pressure on chief executives and the NHS in terms of delivering on this. So, but the media can be a friend as well as a foe. So make sure we harness the opportunities of this external reinforcement and also influence it. If you are wanting to change your organization, it's not terribly useful if you don't have the skills required for change. So here we are demonstrating the most incredible skills displayed at Amrita. So this is, so just the photos of a routine multidisciplinary antibiotic stewardship meeting. But in terms of providing skills, we need to provide them. We need to give enough time for them to be integrated into how people do their work. We need to do it at an individual and at a team level. And we also need to integrate it into leadership and management training. So there is an understanding of why this has to be a core safety and clinical quality agenda within how we manage our hospitals. So really important, it's integrated into leadership and management training as well. And also we need to think about our own colleagues within infectious diseases, clinical microbiology, clinical pharmacy. Do we actually have the skill mix as well? So we need to think about what we need too. So the last aspect of organizational change is this issue about consistent role models. And this doesn't matter whatever you're trying to, whatever behavior you're trying to get the organization to embrace. So we need role models in AMS in every level of the organization, multiple leaders across, up, down, sideways, and senior management taking personal responsibility. And as I said before, a chief executive with demonstrable commitment and leadership. So just thinking about the healthcare implications of antimicrobial stewardship, we need to absolutely make sure it's embedded in how healthcare is run. This is not an extra, it's not an afterthought. It needs to be embedded in how we run healthcare and actually how we maintain healthcare for the future. Because unless we do this, it's going to be very tricky if we don't have useful antimicrobials. We need to have the governance structures, quality indicators, all supporting this. And it should be a very strong indicator of the quality of care. And I'm not just talking about withholding antibiotics or keeping them at bay. It's about using them appropriately, optimal use. And I feel very strongly that it needs to be integrated with infection prevention, both of which optimize antimicrobial use. And there's a link up here, which is to a chapter on expertise, structures, and organization that's free and describes this in more detail. So just allow me to say why I think it is absolutely critical that AMS and infection prevention are completely interlinked. And one of the reasons is data like this. So this is reasons for antibiotic prescribing hospitals in the UK or in England. The latest results, 2017, unfortunately, the latest report doesn't include this data, but I just want to draw your attention to that 23% for healthcare associated infections. 23%, my goodness me. That's absolutely shocking that we're using that amount of antimicrobials in our healthcare to treat infections acquired within our healthcare, in our watch. So, you know, if we did a little bit better with the infection prevention, we'd be doing a lot better in terms of the amount being used within acute healthcare. And this is data from Europe, and I think this is a really important indicator. So you see that kind of turquoisey color in the middle of that. Those are the antibiotics that are used for healthcare associated infection across European hospitals. This came out in 2018. So 1 in 5 prescription was for the treatment of hospital associated infection. My goodness me. I mean, if you got rid of that, you would really, really reduce the volume of antimicrobials used. And I think this is another reason why they have to be very, very closely interlinked. So just a little bit about quality improvement, if that is your role and you're involved in quality improvement rather than technically involved in clinical microbiology, ID, antibiotic prescribing, but just the kind of quality improvement agenda in terms of lessons for leadership. There's a really strong lesson about redefining challenges as a social problem that can be solved. In other words, involving human action and behavior and not just a technical fix. Framing it as a social process, a sense of community with systems, networks, teams, and a sense of ownership really, really helps. And the other thing that we should be thinking about much more creatively is the involvement of professional organizations and their involvement. And as I mentioned before, research collaboration, not just for the research itself, but actually the collaboration enhances success of delivering what you want to happen in terms of your quality improvement agenda. The other thing we need to absolutely recognize is that even although you think you're the best infectious diseases doctor in the world, or you're the greatest clinical microbiologist or the greatest pharmacist or whatever, don't be fooled. People won't like you giving them advice. They far prefer it from their own peer group. So make sure you work with that peer group and work with the clinicians who have that trusted record and that they are part of the peer group that can really influence their own peer network. And these are the type of leaders which have that authority, which breathe legitimacy into these groups. So we must work with these leaders and embrace their influence, as they are the ones, as I said, can breathe legitimacy. So shifting to considering antimicrobial stewardship from a behavioral perspective. So this is a huge amount of work done by my colleague Esmita Charani, who has really highlighted the importance of looking at antimicrobial stewardship as a behavior. So moving from an organization perspective, which I was just talking about, to the individual behavioral focus, and policies and guidelines completely insufficient to address this. We need to understand the factors that actually influence prescribing and behaviors and decision at the individual level, and culture and context are absolutely critical in this. So many unwritten rules that influence behaviors, well recognized, and this concept of prescribing etiquette is now well described and well recognized. And again, we must recognize that the importance of behavioral influence from clinical leaders, and use clinical leadership and existing clinical routes to influence practice. It makes sense organizationally, and it makes sense behaviorally, and it is supported by all sorts of research backing this up. And we have so much focus on leadership, but much less on using our clinical leaders. And we need to actively involve clinical leaders in our antibiotic stewardship. And that was why it was so marvelous to hear from incredible leaders at the start of this meeting in terms of anesthetics and intensive care, as well as hospital management. And I just want to spend a moment thinking about clinical leadership in surgery, because also this is been work that Sanjeev and I have been doing, and we've been looking at how can we address specifically in surgery this massive burden and antimicrobial resistance, and how can we use surgical leaders much more effectively, and not just surgeons, but also leaders in anesthetics, and also now to think about the concept of perioperative medicine leaders, and this is something that is really emerging and gathering strength, and to recognize that the issues in terms of prescribing in surgery are very different to medical specialties, and we need to recognize that and work within that to try and shape this huge issue of making sure that we protect surgical patients from infections, resistant infections, and make sure that antimicrobials are used as widely as possible to improve clinical outcomes in surgical patients. And we were absolutely delighted to receive funding to work with India, work led by Sanjeev Singh and colleagues in Amrita, but also to work with the most extraordinary anesthetic and perioperative leaders. So this is Ramani Munasinghe, who is really paving the way in this concept of looking at perioperative medicine to address how we can optimize surgical outcomes in terms of infection and antimicrobial use, as well as more broader clinical outcomes. And also we're very lucky to be working with Puneet Dar at that stage in Amrita as another great surgical leader. And there's much work going on there, and it's been just incredible to see the work emerging from colleagues through this collaboration. And any quality improvement issue, its success depends on teams, networks, and a sense of community. And this was particularly recognized in all that work around improving line-related safety and bacteremias related to line care. But it's been repeated over and over again. And this recognition of multi-professional roles, teams, effective networks, and leaders across healthcare, absolutely vital. And we really need to develop a sense of community with leaders across healthcare. I was delighted to hear about the role of pharmacists in the introductory remarks. Absolutely critical. The leadership role of pharmacists in how we run and develop antimicrobial stewardship, absolutely critical. And also, it was an area where we weren't using this extraordinary expertise that had been amassed in the management of TB and really tricky, complex TB within acute healthcare and in the community that pharmacists had, and also in the management of HIV and antiretrovirals, again in acute care and in the community. And I'm delighted to say, out of the project that I was describing with Sanjeev, where we've got the most extraordinary pharmacist, Brinda Namputheri, who is doing a PhD and has already published work in developing the role of the pharmacist and what is needed in terms of contextualized training. And it's, this is another future leader for us in terms of developing the role of pharmacists, but way beyond the individual professional role, but related to improving antimicrobial stewardship more generally. We heard nurses being mentioned. I just want to echo how critically important this role is, and it's something we should be doing much more of. And leadership in nursing is something that is absolutely critical in this agenda and mustn't be ignored, and we could do much better with this. And I'm, of course, talking mostly from acute healthcare environment, but we need to take a whole healthcare economy approach. It is utterly ridiculous, this kind of everything just happens, behind the walls of the hospital and everything out there, it doesn't matter. I think it's quite extraordinary, the interest in a kind of One Health approach, looking at livestock and the environment, when actually across healthcare, we can't have a one Health approach across community, long-term care, acute care, etc. So it's really important that we look at leadership and antimicrobial stewardship across our whole healthcare economy, and that we work far harder at joining all of this up. And finally, leadership in the research agenda related to antimicrobial stewardship, absolutely critical and really important that we cross research boundaries. We're integrating social sciences research, but also how important to integrate the kind of data revolution and artificial intelligence, as Sanjeev mentioned, but with also fundamental understanding of context, implementation, and the roles and behaviors of people, and also addressing massive issues of inequity and not compromising access. And then finally, there has recently been an exercise looking at what are the research priorities in terms of optimizing antimicrobial use. So this is not about looking at a new target molecule, developing a new drug. We already heard, the well is pretty, pretty dried up. We're not seeing much. We've got to work really hard at maximizing the effectiveness of our existing agents and any that might come along. And these were the 4 areas that were picked up in a big piece of work with international authors supported by the Wellcome Trust. And these were the 4 areas that we need to look hard at in terms of research: policy and strategic planning, medicines management and prescribing systems more generally, opportunities with technology and innovation that's already out there but it's not being applied, and also the critical importance of context, culture, and behavioral research to address antimicrobial optimization. And leadership fits across all of those domains. So back to you, Sanjeev, and thank you very much indeed. I'm going to mute myself. Thank you.
Thanks, Alison. It was such a pleasure to hear you. I think I was taking notes of almost all slides which you were mentioning, and who best could have delivered the leadership role than you. You mentioned about vision, you mentioned about stepping back and creating leaders. And we have seen this for so many years, Alison doing it, creating more leaders in IPC and AMR. And she did talk about role models, and we have been so fortunate working with her, and we have seen her as a typical role model for AMR and policy making. And she covered almost everything: clinical pharmacist role, nursing, leadership, economy, research, and fantastic. It was incredible presentation, and it was such a pleasure to hear you, Alison. Hope you would stay back for some more time till the question answers session is on. Okay, right. So we will move on to our next presentation, which is by Dr. Nasia Safdar. Dr. Nasia is, she's a graduate from Aga Khan University Medical College, and then she did her residency in internal medicine and fellowship in infectious diseases from University of Wisconsin. She also holds affiliate appointments in Department of Population Health and Division of Geriatrics, and also Systems Engineering. She's a Vice Chair of Research in the Department of Medicine and Medical Director for Infection Control at University of Wisconsin. She received a President's Early Career Award for Scientists and Engineers, the highest honor bestowed by US government, and the John Q. Furman Award for Excellence in Patient Engagement. And it is such a pleasure to work with Nasia, and also thank you, Nasia, for agreeing to deliver the talk and participating in our workshop. Nasia is going to speak on turning the tide of AMR through antimicrobial stewardship, the human factor engineering. So over to you.
Hello, my name is Nasia Safdar from the University of Wisconsin in Madison, and I'm delighted and honored to be here today speaking to you about turning the tide of antimicrobial resistance through antibiotic stewardship using a human factors engineering framework. So the objectives of the session today will be to review human factors engineering principles in the context of antimicrobial stewardship. To do so, we will examine a case study where we undertook an intervention to reduce fluoroquinolone overprescribing and looked at C. difficile infections as an outcome. And this would serve as an example of human factors engineering. Admittedly, this is done in a tertiary care setting in the US, but I think you will see that many of the principles that we used can also apply to countries around the world. And finally, we will examine some real-world examples of human factors ergonomics tools to improve antibiotic stewardship. So the reason that I use C. diff as a classic example of a pathogen to apply antibiotic stewardship to is that it is a very complex and difficult to control pathogen, as we know, and it takes equal amounts of infection control and antibiotic stewardship to be able to achieve control. But really, the same approach could be applied to any pathogen, and also to pathogen-independent horizontal stewardship measures that affect more than one pathogens at a time, which is also true for C. diff stewardship. If you're trying to reduce C. difficile, you might also happily find that you have reduced other antimicrobial resistant pathogens as well. But the challenges that we see to C. difficile containment are listed here, and you can see that some of them center around the fact that we don't really know the incubation period of C. difficile, that there are multiple reservoirs, and that as a spore-forming organism, those spores hang around for years and years in hospital and other healthcare environments. This environmental persistence makes it very easy to catch C. diff if you're hospitalized for whatever reason, and if your gut microbiota is primed to be able to receive C. diff, such as getting antibiotics for another reason. This multidisciplinary approach to containment also makes C. difficile control challenging, because when there's multiple people involved in containment of a pathogen, there's a lot of role ambiguity, and you might think that it's someone else's job to do a certain aspect of containment, and they might think that it's yours. And until that clarification of roles happens, we will continue to find that C. diff will be a challenge. For this reason, we have proposed an integrated framework of infection control and factors engineering principles, which I'll get to in a moment here. But the idea is that working in silos as the Department of Infection Control and the Department of Antimicrobial Stewardship is not likely to achieve the synergy that we need in order to do an effective job of containing healthcare-associated infections in healthcare settings. And so some of the principles that I've listed here in the middle, which would be the backbone of a stewardship and an infection control collaborative team, would be effective conflict management, strong joint leadership. I cannot overstate the importance of that. Readiness for change, which is something that needs to be assessed at each facility and each unit level, depending upon where the intervention is being conceived, and really committed team members. These things happen to some extent in all healthcare systems, but to make it a formal program and a formal approach to this collaboration is really important, because then you can evaluate it and assess it and improve it continuously. And this is a diagram showing the complexity of C. diff. Now, if you're thinking about stewardship for C. difficile prevention, for example, I mean, again, this could apply to any pathogen, really. You'll want to focus on the aspects that are most pertinent to where you think you will get the benefit from if there were some stewardship intervention to be done, which is on the lower left-hand corner of this slide. And you can see that some of the things that places do is that they might review antibiotic use in all cases of C. diff. They might ensure that there's appropriate treatment algorithms that are in place to make sure that people aren't being under or overtreated with C. diff, because that will have the potential of downsides in both directions, and to provide feedback to clinicians and to facility leaders. In the US, this has become particularly important because publicly reported healthcare-associated infections mean that hospitals will incur a financial penalty if your rate is higher than what it is expected to be for a facility of your size. And so in addition to the emphasis on patient safety, this financial and economic aspect that hospitals have had to contend with have made it very clear that C. diff really needs to be front and center when it comes to stewardship. The other tricky thing about stewardship is that, and I'll again use C. diff as an example, that it is not the individual antibiotic use that is solely responsible for rising rates. It is a facility level or a unit level antibiotic use, which may be a major driver. So if I show you this next slide here, this is in a nursing home setting. And so these were nursing home residents with direct antibiotic exposure and nursing home residents without direct antibiotic exposure. On the x-axis, you have antibiotic use. On the y-axis, you have C. difficile infection incidence per 10,000 resident days. And you can see that in both settings, whether the resident received a direct antibiotic exposure or an indirect antibiotic exposure, as antibiotic use went up, so did the C. difficile infection rate. And so the advantage to then having the stewardship program applied to C. diff is that even people who aren't receiving antibiotics can benefit from the intervention. Now we move on to human factors engineering principles. And the one that we use, there are many frameworks. The one that we have had the most experience with is the Systems Engineering Initiative for Patient Safety. And the whole purpose of using a human factors engineering is that when you're looking at things as a system, you will be able to anticipate unexpected collateral, either damage or benefit that you might get from an intervention. You'll be able to make sure that people actually have the ability and the effort and the time in the big scheme of things to be able to do the things that everyone has agreed need to be done. So an example of this is on the left hand of this slide is the five-pronged aspects of the Systems Engineering Initiative for Patient Safety, which I will call SEEPs. So there's technology and tools, there's organization, person, tasks, and physical environment. And all of these have to be evaluated and assessed when you're doing any kind of intervention in a healthcare system. Now, ordinarily, when we think of stewardship, for instance, we typically don't think of the physical environment as necessarily a big aspect of it, but it actually is. If you think about busy emergency room departments and how people are entering orders and where they're located, can people hear the discussion between teams on antibiotic stewardship or really any aspect of patient care? Those things become important but aren't often thought about. All of this, when done in a systematic manner, will lead to processes of care, such as a robust stewardship program in this case, which will then lead to important and relevant outcomes, which is outcomes for the patients and outcomes for workers as well as the organization. The latest version of SEEPs is called SEEPs 2.0. And the addition here, so you'll see the left-hand side looks the same. It's that five-pronged approach. In the middle there is patient work. And patient work may be relevant to some aspects of systems engineering, depending upon the intervention. For example, in coordination of care. It might also be relevant when it comes to stewardship in areas where antibiotic use is readily available, such as many parts around the world. And if that is the case, then education of the patient and interventions with patients at the center of it is likely to be very helpful. Several years ago, we undertook a study on the engagement of patients in antibiotic stewardship. And in the inpatient setting, it became pretty clear that at least in our facility, they get a little cup that is filled with pills several times a day, and no one really tells them, and it's not labeled, there's no packaging on it, so they don't really know what they're getting. And so unless really someone takes the time to explain that this is an antibiotic and what it's doing, they'll just swallow the pills and not even think to comment on what it is that they're getting, which leads to, trust in the health, or is associated with trust in the health system. But of course, with stewardship, there are many other ways in which patients can be engaged. And I think ambulatory stewardship is a perfect example of that, where shared decision-making is really crucial to minimizing inappropriate antibiotic use and promoting collaboration. So how do you apply this generic SEEPS model that I just showed you to SEEPS when it becomes specific to antibiotic stewardship? This is a beautifully created SEEPS model as applied to antibiotic stewardship, and you can see how exceedingly complex it is. So some of the bullet points here are just examples of the things that we need to think about when we're devising an intervention. What are all the things that could be relevant here? And they may not be relevant in all settings, but that this is a good framework to use and as a checklist to think about things that you may otherwise not have thought about. And you can see the outcomes. There's a long list of patient outcomes, clinician outcomes, and societal outcomes. And so a lot is very intervention specific, but this at least gives you a really good holistic view into what is likely to be necessary. And, some of these are maybe related to the electronic medical record, for instance, and I realize some places may have it in some, maybe not in the optimal form, and perhaps it's not even there yet. Maybe it's still paper charts. But either way, I think the framework can help you adapt to your setting. So here's how we applied SEEPS to antimicrobial stewardship, and I'll use C. difficile as an example here. All of this, the underpinning of this is the Infectious Diseases Society of America and their guideline for how to effectively implement an antibiotic stewardship program. They really make no mention of human systems engineering because this is more about these are the things that you need and less about how will you get to an effective stewardship program and what is the process for developing that. The SEEPS framework is really most effective for devising the process of doing it. So they talk about potential process measures and potential outcome measures. And I think depending upon what intervention is planned, these are all extremely relevant. In our case, we chose to look at antibiotic use as far as the process measure and C. difficile infection as far as the outcome measure. So fundamentally, as we all know, there are two core principles. There's audit and feedback, and there's pre-prescription authorization. Audit and feedback meaning that you allow people to prescribe as they will, and you give them feedback on their actions afterward. Pre-prescription authorization is that you don't allow prescription at the outset and either direct it in a different direction or require that they have a conversation with someone who's an expert in stewardship before they would be allowed to, and they meaning frontline providers or prescribers would be allowed to prescribe it. Both of these are effective, and no one really knows whether one is more effective than the other. So many institutions will have some version of either or both of these. This I thought was an interesting study from the Netherlands where they looked at a participatory approach to appropriate antimicrobial prescribing. This is something that I think we all could do a lot of in all parts of life, but certainly in the realm of stewardship, unless you have a commitment from the frontline workers who are actually going to be prescribing antibiotics, no amount of protocols or policies or procedures will really work. And I think in this case, what they did was, which I found very interesting, is the appointment of an antibiotic ambassador, which is similar to what a stewardship individual would be, but much more participatory, much more engagement of stakeholders. And the collaborative decision about which intervention to implement in which unit, and a collaborative decision on what outcomes one would like to see, rather than imposing this is what must be done and this is what will be measured. And so what they found was on the top part of the slide is that in the baseline period, they had very low antimicrobial appropriateness for the syndromes that they assessed. And after the intervention was put in place, appropriateness climbed to a pretty high level. This is in the setting of no real decline in the overall antimicrobial consumption, but showing that even though overall antimicrobial consumption didn't go down, the appropriateness of antibiotic really went up. So it was a success in this collaborative approach. So I strongly believe that for any intervention to work, you have to have a consensus on what is being done, what the indications will be, guided by a review of the literature and your local guidelines and local context, agreement on all the principles, and then piloted to work out all the kinks. And CEIPS can be very helpful in the piloting of interventions as well. So for us, what we did was we implemented a fluoroquinolone pre-prescribing authorization intervention that people couldn't order a fluoroquinolone unless they either went an alternate route or they called a unit pharmacist or even an infectious diseases physician who was on stewardship call. And we gave them a list of alternative antibiotics. It was a very difficult sell to get people to think about reducing fluoroquinolone use because, as we all know, they're oral, they're convenient, and we had become so used to them that they were really workhorses. What helped a little bit was that reports were coming out of side effects of fluoroquinolones and the high rates of C. diff associated with it. And so that made it a little bit easier in some respects to convince people that the time had come to not think of fluoroquinolones as a workhorse antibiotic, but really use it very judiciously for the circumstances in which they were, and no other alternatives were available. So these were the escalating steps that we took, that after speaking to a unit pharmacist, if a provider still felt that a fluoroquinolone was indicated, they would need to contact the infectious diseases consultant or the stewardship team to obtain approval. And because we have an electronic EHR for a few years, we use the EHR as our vehicle for introducing the intervention. But again, there's no reason that this couldn't be done in paper or verbal or any other format, really. So this is what the screen looks like for the prescriber that attempts to order levofloxacin, for instance. You'll see there's a range of alternative options. And for those of you that are into human factors engineering, you will immediately see that the list of options at the bottom is very annoying because it is not alphabetized. And so a busy prescriber trying to figure out, what else they should prescribe is not going to be very happy looking at that list. So it should really be in order of preference, and it should be alphabetized, and ideally by syndrome, so that they choose the right coverage and the right spectrum. So we made those changes after getting feedback from frontline stakeholders. And the web links on the right give them more detail on alternatives. And these are some of the exceptions that we allowed people to use fluoroquinolones for. This was also a surprise to the providers because you couldn't go past the screen until you had clicked on one of these. And so, again, you have to be very cognizant and very aware of not adding to people's time because frontline people are going to be very busy. And then, unlike many other stewardship interventions, we really took the time to figure out the implementation process by doing a lot of qualitative interviews of prescribers, of pharmacists, of frontline healthcare workers, trainees, for instance, and advanced practice providers, to be able to get the best sense of, does it work in their hands, and what sort of unanticipated effects are they experiencing? And those might be in the form of workload or additional clicks or some other glitches in the EMR. So you can see that the fluoroquinolone use in the settings where we had intervened dropped pretty dramatically. On the left-hand side is before the intervention was started. On the right-hand side is after. And fluoroquinolone use declined. C. diff rates also went down. But as we talked about, because C. diff is a combination of infection prevention and stewardship interventions, it didn't have quite that dramatic decline that we were hoping for. But over the years, since we've continued this in place, as well as beefed up our infection prevention measures, our C. diff rates are now fairly acceptable. I mean, if one can consider any rate acceptable, but better than they had been. What we found was that the main indications for fluoroquinolone use in our hands were double coverage, which the ID Society now says is hardly indicated for anyone, especially not for definitive treatment. For empiric treatment, of course, when you don't know what it's susceptible to, when you have a situation where you might have a lot of multi-drug resistant Pseudomonas, for instance, fluoroquinolones may still be entirely appropriate. And this is what we found in terms of the systems effect, that there were a number of calls made to the antibiotic stewardship team, which was quite overwhelming to begin with until people started developing an FAQ type document, and then it calmed down a little bit. People were very concerned about adverse effects because if you couldn't use a fluoroquinolone, might you be asked to use an aminoglycoside? And the nephrotoxicity for that was very concerning. And just the effect of other antibiotic use was another factor but if we hadn't measured this as part of the stewardship intervention, we would not have known how to address it. And likely what would have happened is that people would have found workarounds and figured out a way to still prescribe a fluoroquinolone because there were barriers to their effective engagement that we had not assessed. So making sure that you engage those stakeholders is really important. Now, this will come as a surprise to no one here, But there are a lot of limitations in the studies on antibiotic stewardship, and you can see some of those listed here. There's hardly ever a control group. There are challenges with study design, usually at the level of the unit, including our study, which was an ecologic analysis. Challenges in determining the outcomes, and a lot of delay from stewardship to outcomes. So one of the things, could have been in the earlier days when we didn't see a decline on C. diff, did we just not give it enough time to see whether the decline would occur or not? So finally, I'll also talk about where we did a stewardship study with Dr. Sanjeev Singh's collaboration in Kerala. And you can see this was a qualitative interview study, which is really an essential first step to devising an intervention where we engage stakeholders to see what are the key facilitators and the key barriers. And you can do this using the SEEPS framework and develop questions that talk about each of those 5 things. What is it about the environment that makes it hard or easy? What is it about the tools and technologies you have that make it hard or easy to do stewardship? And you can see that some of the key facilitators that we found are also the things that are really important for stewardship programs everywhere, which is a dedicated committee, for instance, overseeing appropriate antibiotic use, a really prompt and responsive microbiology lab, a high level of stewardship understanding among staff. These are all fabulous facilitators. And some of the barriers that were identified were there was a limited access to clinical pharmacists. And we'll talk a little bit more about this next point, which is, physician immunity to change or resistance to change regarding stewardship policies. So why is this prescriber immunity to change or resistance to change? This is Julie Simzak's work, which is, I think, fascinating because she has applied a social science lens to trying to understand. We all know that stewardship is important. So why is antibiotic stewardship in particular so challenging? And that's because there are a lot of social determinants of antibiotic use. And prescribing is not simply a transactional act, but it is a social act. It is driven beyond clinician knowledge and has to do with how persuasive the conversation is between the people that are concerned when it comes to antibiotic use. And that's what led to the term handshake antibiotic stewardship, which is that your relationships with your frontline prescribers may well determine how successful or unsuccessful one is at promoting stewardship. There is clearly a hierarchy and a prescribing etiquette. And I think we would all agree that if one of our colleagues had prescribed an antibiotic, we would not discontinue it or change it willy-nilly without discussing it with them first. And even though that's understood, it still takes time and effort and communication. And so that all leads to, inertia becoming the predominant factor here. There's a lot of fear in prescribers that if they make the wrong decision or they don't prescribe the antibiotic, that something bad will happen to the patient. And it's a very difficult thing, of course, to get over because we're all used to doing something. So in stewardship, the mantra really is, stand there, but don't necessarily do something. Sometimes it's better to not prescribe, for instance, depending upon the syndrome. But the fear about adverse effects and about fear and risk and anxiety is a real concern that has to be addressed upfront for success in these interventions. And finally, many clinicians and prescribers believe that, yes, multi-drug resistance is a problem globally, but not locally. And of course, all antibiotic resistance is local. And so unless we acknowledge that and have data to show how bad it is in our own local setting, it's going to be difficult to implement change. But the Systems Engineering Initiative for Patient Safety will provide you the framework for being able to do that and gather data on these social determinants as well. So I will stop there and happy to take questions as time allows. Thank you very much. It has indeed been an honor speaking with you today.
Thank you so much, Nasia. It was such a pleasure listening to you. It's one of those very, very difficult topics, human factor engineering and applying SEEPS model in another complex disease, which is C. difficile. And you have done a fabulous work. And it was also a real pleasure working with you to understand the SEEPS in ventilator-associated pneumonia at our institute. And we realized there are plenty of barriers which we still have to work. So thank you so much. And we will move on to our next speaker. It is so good to see you, Paul, after so long. We keep hearing about all the good work which you have done, and in India, they keep telling me if Singapore can do such marvelous work in pandemic, why can't that have an impact in India? and they keep talking about you, and congratulations for all the good work done during pandemic. So Paul is a senior consultant. Sorry, I didn't realize. Thanks, Alison. So Paul is a professor, Department of Medicine, Yonglou School of Medicine, National University in Singapore, and he graduated and post-graduated in infectious diseases from Singapore, and one of those remarkable global leaders who have done phenomenal work in both IPC and AMR, and one of those sought-after speakers, very difficult to get, but sought after speakers and in AMR conferences. He has a special interest in clinical trials and nosocomial infection. And today he's going to speak on another very, very important topic, maximizing antibiotic stewardship through vaccine. So over to you, Paul.
Good afternoon. I'd like to thank the organizers for inviting me to do this session at your meeting. And I'm going to talk to you about the role of vaccines in antimicrobial stewardship and antimicrobial resistance. As some of you know, I'm an academic infectious disease physician. And when people ask me, what does that mean? I tell them I spend most of my time looking after patients, but my promotion depends on my research output and my bonus depends on the student evaluations. So this is a patient that I looked after once some time back. She's an unfortunate lady. She was 39 years old, no past medical history, no travel history, presented to hospital with a 1-week history of worsening productive cough, dyspnea, chest pain, fever, and multiple episodes of diarrhea. On examination, she was hypotensive, tachycardic, febrile, in respiratory distress, with lung crackles and left-sided bronchial breath sounds. You can see from a chest x-ray, she had a massive pneumonia on the left side. In the emergency department, she collapsed. She was intubated and resuscitated. She was started on a combination of amoxicillin, clavulanate, and captazidime, because in Singapore, we are concerned about melioidosis. These were her initial lab results. Her white count was normal. She had a bit of lymphopenia, a bit of neutrophilia, sodium on the borderline, creatinine was normal, glucose a little bit high, ALT, AST mildly elevated. Unfortunately, she collapsed again on transfer to the medical intensive care unit. She had no response to high-frequency ventilation. She was placed on ECMO. She developed VFib after femoral cannulation, and she was severely acidotic. This is her X-ray post-intubation. And again, you can see still dense consolidation with all her lines and tubes in place. In a couple of days, the results came back. It turned out that she had influenza A, H3N2, and her blood cultures came back for pneumococcus with reduced susceptibility to beta-lactams. There was intermediate to penicillin, susceptible to vancomycin, and only intermediate to ceftriaxone. We were unable to wean her off the ECMO. As you can see, her consolidation remained very dense. She had evidence of barotrauma from prolonged mechanical ventilation. Unfortunately, one morning during rounds, her pupils turned out to be fixed and dilated. We did an urgent CT scan and found that she had a massive intracranial hemorrhage. And we were faced with a dilemma. Do we continue the ECMO with the anticoagulation and allow her to cone, or do we stop the ECMO? In the end, we stopped the ECMO and she passed away. So this is an unfortunate young woman who had a combination of influenza and pneumococcal bacteremia, both actually vaccine-preventable illnesses. Just as a qualifier, often ECMO does work in vaccine-preventable illnesses, and this was a young woman from Nepal, actually, who came to Singapore, was living in Singapore. She had H1N1 pneumonia. She was intubated. She developed ARDS. She was put on ECMO, and she was actually pregnant. She delivered the child, and even though we couldn't decannulate her, we allowed her to hold on to the child. even while she was maintained on the ECMO. So what is the impact of vaccines on antimicrobial resistance? We all know that vaccines do save lives and they have a tremendous impact on public health. But this is based on an article that was written in the International Journal of Infectious Diseases by a group from GSK and myself, where we looked at the potential impact of vaccines on antimicrobial resistance, trying to understand what part vaccines play in the conventional understanding of AMR, which, as you know, is driven largely by antimicrobial misuse in humans and animals, and the traditional approaches that have been used, such as stewardship, infection prevention, promoting research and development. But vaccines are increasingly a factor which are being considered into this equation. So we argued there are a number of ways that vaccines can impact antimicrobial resistance. Firstly, by preventing disease and the proliferation of bacteria. Secondly, by reducing antibiotic use through fewer infections. Thirdly, by mechanisms of action which are less prone to induce resistance. Fourthly, by preventing resistant strains from occurring and spreading. But we also recognize there are some limitations to the roles of vaccines in the prevention of this AMR crisis. Again, as you all know, vaccines are the only way to eradicate a disease. Smallpox, the only human disease eradicated from the face of the earth through vaccination. Next in line is polio, which is very close to that, thanks to an efficient vaccination program. Measles, another disease which is fast becoming eradicated. This has been achieved in spite of the fact that there are significant swathes of population which have not been fully vaccinated. But careful, targeted programs have ensured that we are moving along towards measles eradication in many parts of the world. Now, one of the reasons why these programs have been successful is because vaccines are now manufactured all over the world. In fact, more than half of the UNICEF vaccines which have made polio history in many countries are on the way to eliminating measles are made in developing countries. And this is through mechanisms such as a patent pool or the waivers of patents, which have allowed developing country manufacturers to produce these vaccines. And this has allowed the prevention of disease. And once you don't have disease, you're less likely to be in hospital, you're less likely to acquire a resistant pathogen. So that's the first approach. The second approach is by reducing antibiotic use through fewer infections, through preventing viral diseases prone to bacterial co-infection or superinfections, and preventing antibiotic misuse. So the first case, which I told you about, the lady with the influenza complicated by pneumococcal bacteremia, you could argue that if she didn't have influenza, she wouldn't have pneumococcal bacteremia. And so she wouldn't have been at risk of penicillin-resistant or penicillin-intermediate pneumococcal bacteremia, which eventually killed her. Now, penicillin-resistant pneumococcus, again, we've seen the impact of the early vaccines, like, for example, the PCV7, which had a significant impact on reducing pneumonia hospitalizations. And again, once you're not hospitalized, you're less likely to get multi-resistant bacterial infection. In terms of large-scale interventions with influenza and 23-valent pneumococcal vaccines in elderly persons, this is a large study which was conducted in North America. And again, basically, they showed significant reductions in influenza, pneumonia, invasive pneumococcal disease. In Singapore, we've looked at the impact of pneumococcal vaccines on pneumococcal carriage and also on antimicrobial resistance. And what we found is actually the rollout of the PCV7 vaccine had a significant impact on the carriage of vaccine strains, although there was some degree of replacement by non-vaccine strains, which is why we're moving further and further down to PCV10, PCV13. Now, the question is, would universal influenza immunization have an impact on antibiotic prescriptions? And this is a study done from Canada, where they looked at the impact of universal influenza vaccination in the province of Ontario. And they looked at the changes in antimicrobial prescribing. And they did see that universal influenza immunization was associated with reduced respiratory antibiotic prescriptions. although the impact was not huge, but it was there, and that in a way is a kind of proof of principle with the introduction of the universal influenza immunization program. When they looked at the relationship between change in respiratory antimicrobial prescribing and influenza vaccination, and they compared the province of Ontario, which had the very high rate of vaccination, they found that it actually was significantly associated with antibiotic prescribing compared to other provinces which did not have a universal influenza vaccination program. So there is some evidence, not a huge amount, but there is some evidence that universal influenza vaccination can reduce antibiotic prescribing. A similar study was done in Texas, where they actually looked at ambulatory patients with acute respiratory infection and compared the vaccinated with the non-vaccinated using a huge data set with more than 30,000 cases. What was interesting was among the vaccinated that were influenza positive, you still had 28% of them who were prescribed antibiotics. The non-vaccinated who are influenza positive, another 24% were also prescribed antibiotics. So although there did seem to be a reduction in the proportion that were prescribed antibiotics, we still have a long way to go. In the UK, there was a modeling study that was done looking at the impact of live attenuated influenza vaccination on adverse health outcomes associated with antibiotic resistance. So this is not just prescription, this is actually looking at dailies, cases, and deaths. And the suggestion was that overall, there would be a beneficial impact, and it would be most significant in certain age groups if it could be widely rolled out. So there are small studies which have been done in different settings, and if you combine them together, this was a meta-analysis and systematic review of the impact of vaccination on antibiotic usage, and overall it did seem to suggest that there would be a reduction in antibiotic use with widespread, basically influenza vaccination in different populations, primarily in the older adults with chronic bronchitis. The impact on COPD might not be that great, but also there would be an impact on infants and children up to 14 years of age. Again, looking at this category for pneumococcal conjugate vaccine, there would also be a slight impact in reduction of antibiotic prescriptions. So influenza and pneumococcal vaccine, which could potentially have helped my patient, there is some data suggesting that they are beneficial overall in reducing prescriptions. Now, the whole question about resistance, as we all know, resistance results from suboptimal use of antibiotics. What about vaccines? So the argument has been that vaccines are far less likely to induce resistance than antibiotics are. And this is a paper published in PNAS about 3 years ago, where they looked at how quickly resistance developed once antibiotics were approved. And you can see penicillin G, within a few years, we had resistance. Even vancomycin, which went for a long time, resistance developed. Carbapenems, resistance developed. And the new drugs, my goodness, daptomycin, ceftaroline, within years or months to years, we have resistance evolving. On the other hand, vaccine resistance has taken a really long time. It's taken decades to emerge. Some exceptions include the hepatitis B virus, or as mentioned earlier, some of the strains of the pneumococcal carriage, but that again is being overcome by the development of newer vaccines. There's a lot of concern right now about the COVID vaccines and immune escape, but so far that has not proven to be a major concern. But again, like with hepatitis B, you can just tweak the vaccine if you need to. Next point is this issue of preventing resistant strains from occurring and spreading. Now, there's a lot of concern about antimicrobial resistance, and the belief is that it's just one sort of blanket problem that you've got overuse of antibiotics, you get selection of resistance. But in reality, it's actually a lot more complicated than this. And again, as you all know, the NDM strain, which emerged from India in 2008, went to Sweden, the UK, the US, came to Singapore in 2011, and essentially is seen all over the world. In the US, the KPC strain first emerged in North Carolina in 1996, crossed the Atlantic, went to Israel, went to South America, and interestingly enough, there's a strain from China that reached Singapore in 2004. And whenever I used to give this talk in India, people would ask me, why isn't it called the North Carolina carbapenemase? And I used to say, I have no idea. And as you know, nowadays we can't name viruses or bacteria after places. I'm just waiting for the name to be changed for this one. But anyway, besides that, so the problem of carbapenem resistance has been associated with particular clones, plasmids, and it's been spreading globally. In today's terms, we will call them variants. So we actually took part in a large study, the Merino trial, which was trying to spare carbapenems, looking at piperacillin tazobactam versus meropenem in the treatment of ESBL positive E. coli and Klebsiella infections. So we actually turned out to be the largest recruiting center for this global trial. And initially, we thought that most of our patients would be healthcare-acquired infections. Interestingly enough, it turned out that the vast majority of our patients were community-acquired bloodstream infections associated with the urinary tract. And when we drilled down further, the vast majority of them were E. coli ST131. Which would now be considered a variant or a clone. So E. coli ST131 has emerged as a major cause of ESBL, or extended spectrum beta lactamase producing gram-negative bacteria. Similarly, with Klebsiella pneumonia, you've got Klebsiella pneumonia ST258, which has spread all over the world. It's now endemic in many, many parts of the world, in Europe, North America, and in parts of Asia. The reason why these endemic clones are so successful is unclear. But interestingly enough, they have the potential for actually doing something in terms of the use of vaccines. Because again, as you know, what happens is that you get a non-vaccinated patient gets infection, they may receive antibiotics, the infection may not be cleared. There is also this possibility, and again, you get resistance emerging, as I mentioned earlier. There's a possibility if you have a vaccine which can actually prevent this particular infection, then you may be able to do something about this. And we have had many years of trying to get a Staph aureus vaccine, but the antigenic heterogeneity of Staph aureus has made this very difficult. However, there has been this 4-antigen Staph aureus vaccine to try and reduce the incidence of 4 major clones of Staph aureus, or USA 300, PFAS 0158, 0186, and or depending on whether you're using the sequence types, SD8, 28, 57, and 25. And it seems to be reasonably successful in preclinical models. Now, it's not going to prevent all Staph aureus infections, but if it prevents the most serious or the most resistant, then it's going to, I think it's reasonable. And I think now with this COVID pandemic, the bar for a successful vaccine has been set a lot lower than what we used to expect in the past. So there is an interest in developing Staph aureus vaccines that perhaps could be given to individuals before they get admitted to hospital, or say before you go for your knee replacement or cardiac surgery, you get an MRSA vaccine. And I think that's something that's not too far into the future. Finally, there are some limitations in the roles of vaccines in the prevention of the AMR crisis. We've tried, I was involved in a study looking at a C. diff vaccine, recruited thousands of patients all over the world. Unfortunately, the C. diff vaccine was not successful and it didn't perform significantly better than placebo. But still, we press on. And part of the reason why we press on is the sad reality of the way medical research is conducted these days. A lot of it is driven by pharma. And as you can see in terms of the number of new licensures, the number of antibiotics, the golden era of antibiotics was probably the 60s, 70s, and 80s, when you had plenty of new antibiotics licensed. But now there's hardly any new antibiotics licensed. There's a ton of vaccines that are being licensed. And this is before the pandemic, when you had a slew of vaccines which had been licensed globally. So the reality is that industry is right now far more interested in investing in vaccines. And as a community, the infectious disease and microbiology community needs to step up. And as they say in academia, unfortunately, we go where the money is. And this is my favorite slide, which I show to medical students whenever I get a chance. It's a reality check. It's the infectious disease mortality in the United States in the 20th century. And what you can see is that infectious disease mortality dropped significantly throughout the 20th century, with a spike with the influenza pandemic, small rise with HIV. But it dropped long before the first use of penicillin and long before the widespread use of polio vaccines, which were a major killer in those days. And the reason why infectious disease mortality dropped was because they chlorinated the water and they introduced housing rules. So you couldn't get 20 people living in a room like you used to have in New York or Los Angeles. And that dropped the rate of tuberculosis. The chlorination of water dropped the rate of salmonella, S. typhi infections. And essentially what I tell the medical students is deaths from infectious diseases dropped not because of doctors, antibiotics, or vaccines, but rather because of the engineers. So reduction in antimicrobial resistance is a One Health approach. It's not just clinicians, microbiologists. It also involves engineers and the whole community. If you have any questions, please feel free to email me. Thank you very much. I will be around for the question and answer.
Thank you, Paul, for that lucid presentation, and it is always such a pleasure listening to you. And I never realized that Staph aureus vaccine is also is on the anvil, and your last slide was very impactful, and I think every student should see that slide, because that conveys lots of messages. So I'll quickly go over to some of the questions. We do have less time, but nevertheless we'll take. There have been many questions in a QA box, and Alison, if I can ask, there's a doctor from Bangladesh who is basically asking, you mentioned about accountability pathways and clear lines of accountability. In my country, it is very difficult to put this accountability in practice. So since we are discussing antibiotic stewardship in LMIC, how would you suggest that this accountability pathway can be practiced? Alison? Yeah, she needs to be unmuted.
Right, I've unmuted. Great, thank you for allowing me. So, you know, some of the things that we were talking about, which was, you know, acting local, but thinking nationally and internationally. So it may not be that one can change everything nationally and the frameworks for quality indicators or regulation or monitoring what people think is quality or standards within healthcare. But you can certainly try and influence that. And it really sounds like that's happening already, but you can also think about locally. I mean, locally at the level of your organization that you work in, or locally within one's own team or one's own service, or how you work together. So it can, you know, it can be at multiple levels. Just because it doesn't have a massive external reinforcement in terms of national guidelines for accountability doesn't mean to say that you can't look at that locally at multiple levels. I worked for a while in the US as a ID fellow, and I just couldn't believe how much accountability we had to have in terms of every prescription advice being looked over. When I came back to the UK and the NHS, I finally thought, freedom, nobody's looking. And then I was really horrified to discover we did not have any kind of accountability. And I didn't mean at the level of the ID and micro people, I meant within the organization, but that all that has changed. So I think even if there isn't something nationally, you can do something at multiple levels within your own team and organization. Thank you, Sanjeev.
Perfect. Thank you so much, Dr. Sumanth. There's a doctor from Nepal who is asking, you mentioned about 30 to 50% of the antibiotic use is in a primary care is inappropriate in LMIC, and you mentioned about India, Bangladesh. So he's asking, how do we, are there any countermeasures for inappropriate prescription at primary care? Because it is they are unable to do it in select tertiary care, they are unable to do it in secondary care. So how do we start? Yeah, IT team needs to unmute Sumanth. If IT can unmute Paul, Sumanth, and Alison, it would be great. Can you unmute yourself, Sumanth? Does it work? Doesn't.
All right, now I can. Okay,
yeah,
good.
perfect.
All right, thank you. All right, so for the question, what can we do or where to start for addressing the inappropriate use in the primary care? I think one of the slides that I was talking about is the investment that WHO has done to improve antibiotic prescribing in the primary care setting is the antibiotic book that's already out. It's in the public consultation page right now. But that book will be released in the spring of 2022. Essentially, that is basically a resource for any healthcare provider prescribing antibiotics. That will serve as a resource, with actual guidelines when to prescribe antibiotic, what antibiotic, and the dose and duration. So, that is what that's really a serious concern that was identified when looking at the LMIs in low-income countries. And there's, as you know, there's a lot of use in the community. Antibiotic use happens, majority of the antibiotic use happens in the community, and addressing that is the biggest challenge. And accordingly, the WHO antibiotic would be able to help.
Perfect. Thank you so much, Dr. Sumanth. Paul, there's a question for you. In an OPD setting, are there any, this is from your nearby country, this is a doctor from Philippines, are there any age-appropriate vaccine which we can prescribe other than what is generally there during the pediatric visits?
Yeah, we have a campaign actually at the university. We picked it up from one of the other hospitals to try and promote influenza and pneumococcal vaccination. And it's not been very successful. Partly it's related to reimbursement. So in fact, it works better if we do pre-discharge vaccination, because then it can be incorporated in the overall hospital bill. The healthcare financing system in Singapore is really complicated. So, we don't have an NHS like you do in the UK. So we are trying to promote influenza and pneumococcal vaccination. And I think that would, because, a lot of antibiotics are prescribed in the outpatients, I think, for acute respiratory infections. So if you can reduce the incidence of acute respiratory infections, then you are going to reduce the incidence of antimicrobial prescribing in the outpatient setting, I think. Over.
Perfect. Thanks, Paul. I would like to ask Alison, Dr. Sumanth presented Nina Zhu's paper, and it was very, it is so interesting to see that your team's paper is being presented by Sumanth and by Nasia, and your team is doing fantastic work. But the Nina Zhu's paper in CMI says antibiotics in UK increased during COVID time in the second wave. So are there any learnings? Because we have realized in India, almost everybody has taken hydroxychloroquine, everybody has taken ivermectin, everybody has taken azithromycin, everybody on earth has taken doxycycline during COVID time. So it has, I don't know what mess we would have created, but since she published this, what would be your response? How do you see this?
So, I mean, I think it was really interesting at the beginning of COVID, this kind of massive increase of antimicrobial use within acute care, but actually really quite badly reported, like not, the severity of illness not being reported, and people not quite understanding when and how antimicrobials were used. And then kind of analysis showed that actually co-infection was really, really pretty rare compared to antimicrobial use. And then it was, I think it was in May last year, the WHO came out with the recommendations about it's not needed in less severe disease. And I think the data that Nina showed demonstrated how much learning there was. Initially concern, data came out, really got to grips with antimicrobial stewardship within acute care. So that was a real change. Initially a problem mostly in ITU, but then it came under control. What I think is really interesting is that in this issue about the major concern about antimicrobial use on AMR in the context of COVID, when actually the bulk of antimicrobial use is in the community. And certainly in the UK and in Europe, there's been a massive decrease in antimicrobial use within the community. So a huge decrease, and some of that might be really good, but some of it may be related to lack of access because of disruption to healthcare, etc. So I think it's really important we look at that data very, very, very carefully. Thank you.
Right. Thanks, Alison. So Sumanth, this is Dr. Raj Lakshmi asking, you mentioned about 114% increase in consumption of antibiotics in LMIC. So has the diagnostic improved? Has the access improved? Has the standard of living improved? And has the overall prescription pattern improved? Or is it all inappropriate, which is leading to 114% increase?
Right. I mean, so I think it's all. Unfortunately, it's hard to tell, why there is a increase in low-income countries. But definitely, one thing is for sure: there is an increase in the access to antibiotics. No doubt about that. But how much is that appropriate is the question that it's really hard to pinpoint. But as I mentioned in my slide, there were there's one study we published looking at the inappropriate use in primary care. So we know there is at least 30 to 50% of the antibiotic used in the primary care is inappropriate. So the rise in the use is increased access because people, or at least the countries can afford more now with respect to the people income has increased, so there is more leverage to getting these antibiotics. And also remember, there's a slew of generics markets. As India is one of the largest producers of antibiotics, and there are so many generic antibiotics now, so the cost has gone down. So I think that's also playing a major role. So I would say it's a combination, mainly increased access, but there's certainly a huge component of inappropriate, and the COVID is a perfect example that what we saw, what happened in India. As you said, as we published, everybody got an antibiotic, COVID. This is after the guidelines came out from the WHO saying that there is no role for antibiotics. So.
Great. Thanks, Sumanth. Dr. Paul, there is a preemptive question. Is booster recommended for COVID? Sorry, Team IT needs to unmute Dr. Paul. Yeah, please go ahead.
Okay, yeah, so this is the million-dollar question. And to answer the question the way everybody wants me to answer it, this afternoon I got my booster dose. I got a different version from my first 2 doses. I'd been holding out for a long time because I know that the companies are doing clinical trials of variants, And I'm just so annoyed that they're not coming out with the variant. And I was hoping to register for a clinical trial of a variant booster, but they're nowhere near moving that out. So, so the bottom line is, we don't really know. The data that we've seen about boosters has been very small data, very short follow-up periods. But again, the question is, are these really boosters, or are they just the normal dosing? Like for hepatitis B, you give 0, 1, and 6 months. So we have no idea what's the actual regime that should be used. So I see Alison's just dying to chip in. Alison, have you had a booster? But she's muted too.
Yeah. If you could keep
okay, she says she's nodding her head. Yes, she has.
Yeah, perfect. Team IT, if you can unmute Sumanth, Paul, and Alison, it would be great. So the answer is yes.
Well, probably, yeah.
Yeah. So we'll
and again, I think for certain categories, like our transplant patients, with 2 doses of vaccine, they have miserable responses. So I think the immunocompromised, definitely, there's no question about it. We've had some very elderly patients who have very poor responses as well. But when you're talking about a person who thinks he's fit, 50-something-year-old that's like me, then I think it's a matter of trying to weigh up.
Yeah, thanks, Paul. Team IT, can you just unmute Alison? This is my last set of questions. So there is Dr. Gupta who is asking regarding your work in surgical services. And Alison, the question is that most of the surgeons would prescribe antibiotic because they don't want to, there is a fear, they don't want to lose the patient, and it implicates directly on the professional skill of the surgeon. How do we correct that?
So yeah, what an important question, and that is precisely why it's so important that we look at infection prevention as a key aspect of delivering clinical excellence in surgery, as well as the surgical skills, and integrate that infection prevention aspect along with the antibiotic usage. And I think the message is not about controlling antibiotics. It's about, the best possible care for that patient, as well as the patients around them. And I think getting that message and getting the absolute involvement of the surgeons and the broader surgical team is really critical. And I think some of the work being done certainly in Amrita is going to kind of support that and emphasize that further. And also getting the surgeons involved in research. And I think, following on from some of what Paul was saying, I think there may be a real opportunity for not just the role of vaccines in terms of preventing surgical post-operative infection and ITU infection, but also of immunomodulation, monoclonals, who knows, in the future. And we need to involve our surgical colleagues in the broader aspects of research as well. But I think the message has to be about the clinical care of the patient and not the kind of control of antimicrobials. And we've got to involve the protecting from infection in that, as well as surgical skills. Thank you.
Last question, Sumanth. You mentioned you were part of the team who did that AWARE classification. So there was Dr. Nasia mentioned about pre-authorization. So should LMIC start with reserve drug surveillance program? Should they start with pre-authorizations? Since you are so familiar with our demography and geography, how do LMIC, if they need to, from 5 days after the workshop, get started? What do they do? What are the 2 takeaways?
Right. I think that's been discussed about how to incorporate the AWARE tool as aware classification as in stewardship tool. I think the focus should be on the watch antibiotics. The watch are the, which includes the cephalosporins or third generation cephalosporins and carbapenems. And that's because, those are the antibiotics which drive the use of the reserve antibiotics. Fortunately, I should say fortunately, but the availability of reserve antibiotics is low in many low-income countries, as you know. There's not much availability except for colistin or maybe linezolid, etc. But newer antibiotics are not introduced in LMICs yet. So the focus should be on the watch group antibiotics. So that's a group they need to concentrate. How much are they being used in my hospital? Because the goal is to reduce use of watch antibiotics and increase the use of access antibiotics. And there's a lot of discussion about reserve group in terms of, if we bring those antibiotics, where should we introduce them? Should we just approve in every hospital, or should there be a careful way of assessing, what maybe restrict to a tertiary care centers where diagnostic microbiology lab is available? But I think the way forward would be to focus on watch group of antibiotics should be incorporated into stewardship.
Thanks, Sumanth. My last question to Paul before we end the program. Paul, you are so aware of all the healthcare delivery system within the country, within India. What would be, and you mentioned in your last penultimate slide about One Health. So what could be a good 3 takeaways if I need to sort of get started with an antibiotic stewardship program? What should I do? How should I structure myself?
Yeah, that's like a whole lecture in itself. but I think I'm not an expert on the Indian healthcare system, and I've been around. I've seen aspects of it, and some of it is reflected in what happens in Singapore, because we have a very large and successful private sector, and we also have a very large and almost successful public sector. So I think the issue is that there have to be role models, which Alison was talking about. And people in India and Singapore, they compare. In Singapore, we have the famous hawker centers where people go and queue for different kinds of food. And in general, if you're going to a new hawker center, you go to the place where the queue is longest. You don't even know. Some people do online reviews, but the vast majority of people just go where the queue is longest. So I think, what's going to happen is that people will know. You go to this hospital, you get a multi-drug resistant infection, you end up requiring ceftazidime, maybe Bactam, that's going to bankrupt your family. Whereas you go to hospital B, you can be treated with penicillin, or better still, you don't even get an infection at all. So I think that's the way it has to happen. That you have to have, in a way, a friendly competition, that the private sector, and again, I have more experience in Indonesia, where in Indonesia, there's been a lot of pressure because there's unhappiness that the wealthy have access to private healthcare, which is very good, or they can fly over to Singapore, whereas the poor have access to, not great healthcare. So there's a lot of political pressure to try and improve the standards in the public healthcare system. And I think, there's no question about it. Antimicrobial stewardship is clearly a way of improving the healthcare for your patients, for your communities. In fact, if you allow me one last anecdote, when I joined the hospital, I was the first full-time infectious disease hospital physician at the university hospital, and we are kind of a privatized university hospital. And the chief of the hospital, he came up to me after a couple of years. And he said, there was a lot of question about hiring an infectious disease physician, because usually we put in a lot of money to bring in a cardiothoracic surgeon or a plastic surgeon or a neurosurgeon, because we know they're going to bring in, research, or they're going to bring in patient dollars, which will help support the underfunded public side of the hospital. But he said, I realized that when we bring in an infectious disease physician, you don't bring in more patients, but you bring better outcomes for our patients. I said, that's such a nice thing. I wish you could put it down on my review. but I think that's what antimicrobial stewardship is all about. It's actually providing better care for our patients. And I think everybody will see it after a while, even the surgeons. Over.
Fantastic. That was such a nice anecdote, Paul. It was so reassuring and encouraging that you have a leader like that who would look at clinical outcomes rather than dollars. So we come to an end of today's workshop. It's such a fantastic day, incredible talks, and so good to meet Alison, Sumanth, Paul, Nasia, and so good to hear from the leadership, Dr. N.K. Ganguly, who has been the DG of ICMR, who has run the show for so long, who himself is a prominent microbiologist, Dr. Naresh Trehan, Dr. Gandra, and Dr. Yatin Mehta. So all mentioning the same, or emphasizing the need for stewardship, and there are creating that multidisciplinary team. So thank you so much for your time, accepting accepting to be present here. And I know it's going to be very, very difficult. You've been with us for almost 2 hours, and we really appreciate that. And for all our other delegates who have still hooked on, we have 4 excellent days to go. There are superb presentations which are lined up. So please do get into the link and be with us for the next 4 days. So thank you so much, and have a fantastic good evening, have a fantastic good night, have a fantastic good morning, wherever you are. Enjoy yourself. Thank you.
I just wanted to add one last word, that especially to the 4 speakers, that I am so happy that I just had to write one mail and everybody agreed. I think this is a wonderful gathering, and to hear from such experts is so enlightening, and I'm sure all our participants would feel the same way as I do. Thank you and goodbye.
Thanks, Sharmila, and goodbye to all of you. Thank you so much.